Cardiovascular cardiac disorders 1. Coronary heart disease will occur when the major coronary arteries are partially or completely blocked. Blockage can occur from the coronary artery spasm, arteriosclerosis, or atherosclerosis, and can result in ischemia or infarction of the myocardial tissue. CHD, or coronary heart disease, is the largest single cause of death in Americans. Native Americans and African Americans will develop coronary heart disease at a younger age than other Americans, while the incidence of the disease is highest among middle-aged Caucasians. Latinos, however, have a lower death rate from CHD. So with arteriosclerosis, this is an abnormal thickening, hardening, and loss of elasticity of arterial walls. Lipids, cholesterol, calcium, and thrombi can all adhere to the damaged arterial walls and decrease the vessel lumen diameter. With atherosclerosis, this is a form of arteriosclerosis, and it's an inflammatory disease that starts with an endothelial injury that leads to inflammation and deposit of foam cells. These foam cells can accumulate and progress to fatty streaks, fibrous or stable plaque, and unstable plaque. With the fatty streak, the earliest lesion to develop, we see yellow-colored lipids fill smooth muscle cells, and this will produce streaks of fat without obstruction. With the fibrous plaque, we see a characteristic lesion of progressing atherosclerosis. A fibrous plaque will form on the wall of the artery and extend into the lumen and contributes to the loss of arterial elasticity and impairs the vessel's ability to meet increased oxygen needs. With unstable plaque, the outer layer of the fibrous plaque can actually thin out, making the plaques unstable, and this increases the risk of ulceration and rupture. When a plaque ruptures, a thrombus develops and can partially or completely obstruct the artery. If plaque formation occurs slowly, we do need to realize that collateral circulation can develop. Symptoms: CHD is usually asymptomatic until the tissue's blood supply is reduced by at least 50%. At that point, we can see stable angina, unstable angina, MI, and sudden cardiac death. We treat this with diet therapy, drug therapy, a reduction of modifiable risk factors such as smoking cessation, weight reduction, and blood pressure control. We need to follow the ABCDEF mnemonic, A being antiplatelets, anti-anginal, and ACE inhibitors. B, beta blockers and blood pressure control. C is cigarette smoking cessation and cholesterol control. D is that healthy diet and diabetes control. E, patient education and routine exercise. And F, the flu vaccine. Healthy People 2020 has set several goals that are related to serum lipid levels. One of these is to reduce the mean total blood cholesterol in adults to 177.9 milligrams per deciliter. Angina is a chest pain, and it's the most common symptom of coronary heart disease. It's the result of tissue hypoxia. There's 3 types of angina. We have stable angina, which usually occurs with exercise or other activity and usually will subside with rest. Other precipitating factors will include smoking, physical exertion, emotional stress, and heavy meals. Usually the location is substernal, but it can radiate to either arm, the shoulder, the jaw, the neck, and the epigastrium. The pain is described as vice-like, burning, squeezing, or smothering. The patient may also exhibit diaphoresis, dyspnea, nausea, and vomiting. The pain is intermittent and unpredictable. It usually will last only a few minutes, and again is relieved by rest or maybe a nitroglycerin. Unstable angina is more severe pain that occurs with rest or minimal exertion. It may not be relieved by nitroglycerin or may require multiple doses of nitroglycerin. It may occur in patients who have experienced stable angina that has now changed in the pain pattern or the pain severity. This also could be the first manifestation of CHD. The unstable angina is more serious. These patients are at a higher risk for MI and they're frequently hospitalized. Variant angina is also known as Prinzmetal angina. It's caused by coronary artery spasms and may not be associated with CHD. We see unpredictable pain and it can occur at rest. We also see transient ST elevation on the EKG anytime there's pain. And the usual treatment will be calcium channel blockers to help prevent any spasms. And myocardial infarction. This is death of myocardial tissue that's caused by a prolonged lack of blood and oxygen supply to that tissue area. The average age for the first MI in men is 64.7 years old, and women is 72.2 years old. Risk factors include being overweight or obese, smoking, high-fat diet, hypertension, a family history, being of the male gender, diabetes, physical inactivity, and excessive stress. So let's look at the pathophysiology. This will begin with the occlusion of a coronary artery, and within 4 to 6 hours after occlusion, ischemia will begin to result from a lack of blood and oxygen. Injury then follows, and that is followed by infarction. 20 minutes of ischemia can cause irreversible damage. Within 24 hours after an infarction, we do see the healing process begin. By the third day, necrotic tissue has been broken down by enzymes and removed by macrophages. Collateral circulation will develop to supply the injured area and the scar tissue begins to form. The tissue there, however, will remain weak and very vulnerable to stress until that healing process is complete, which is about 6 weeks later. There are two types of myocardial infarction. We have the non-STEMI and the STEMI, which is the non-ST elevation MI and the ST elevation MI. Usually the ST segment on an EKG is flat, but it will be displaced when there's a lack of oxygen to the heart tissue. In a non-STEMI, there's usually transient or partial occlusion of the coronary artery. In a STEMI, we see total occlusion of a coronary artery from a coronary thrombosis. Complications of myocardial infarction include dysrhythmias. These are disturbances in the heart rhythm that can occur in 80% of MI patients. The rhythm can be fast, slow, or irregular, and it can be life-threatening. We see heart failure. The MI can cause heart failure if the left ventricle is unable to empty efficiently. The increased preload will lead to systemic and pulmonary failure. Symptoms include dyspnea, restlessness, tachycardia, decreased output, hypotension. This can all progress to cardiogenic shock and death if it's not treated. However, it can become a chronic condition. Cardiogenic shock is the most frequent cause of death following an MI related to extensive left ventricular injury. It is more common if the patient has had a previous MI. Symptoms will include hypotension, the cool moist skin, oliguria, and an altered mental status. A thromboembolism. Thrombi can form following an MI, which can break loose and lodge in the lung. Symptoms include pallor, cyanosis, heart failure, A massive PE is characterized by sudden severe dyspnea and is usually fatal. Sudden cardiac death will occur when heart activity and respirations abruptly cease. The most common cause is CHD or a complication of an MI, left ventricular dysfunction, cardiomyopathy, electrolyte imbalance, antidysrhythmics, electrocution, and pulmonary embolism. It usually occurs during ordinary activity and is preceded by ventricular tachycardia or ventricular fibrillation or severe bradydysrhythmias. If these patients survive, they will require CHD treatment, percutaneous coronary intervention or PCI, or coronary bypass graft, which is a CABG, studies to determine the arrhythmia cause, catheter ablation, antidysrhythmic agents such as amiodarone. And the last complication would be ventricular aneurysm and rupture. Weakened areas of the ventricle might begin to bulge and potentially rupture if that tissue is weak enough. If this happens, it is fatal. So symptoms of an MI. We start off having pain, and there is the potential for it to radiate from one place to another. It may be heavy or constrictive type pain with or without exertion, and it will usually last at least 20 minutes. These patients frequently become diaphoretic, lightheaded, have nausea or vomiting. Their skin becomes cold and clammy. They're very anxious or have a feeling of impending doom. Atypical symptoms are common in women with complaints of fatigue, shortness of breath, and atypical chest pain. But we also see atypical symptoms with diabetics and older adults that could include no chest pain, but they do have shortness of breath, dizziness, and nausea. We diagnose an MI through lab and EKGs. The cardiac markers that we look at in the lab would be the troponin, which are proteins that are released from the cardiac muscle when the muscle is damaged. This level begins to elevate within 3 hours of injury, and it will peak in 12 hours and then slowly decline. Cardiac enzymes will help confirm the MI. We look at the CK and the CKMB. These elevate rapidly with infarction within 4 to 6 hours following an MI. And myoglobin is released within 1 to 4 hours following an MI, but it can also be elevated after strenuous exercise or renal failure or neuromuscular disease. The EKG, we see changes through the EKG during periods of ischemia, and we may also see some dysrhythmias occur. Goals of treatment are going to be to limit the amount of cardiac muscle injury to help relieve symptoms and prevent or minimize complications. When we look at drug therapy, initially what we're going to do is administer nitroglycerin, which will help dilate the coronary arteries, administer oxygen to maximize the oxygen that's getting to the tissues with each breath, provide morphine to help relieve pain, diminish anxiety, decrease tachypnea, and help relax bronchial smooth muscle. And all of this helps facilitate gas exchange. And then we administer aspirin for antiplatelet properties. Some of these patients may be candidates for a fibrinolytic therapy to help dissolve blood clots. One of the most common ones would be like TPA or streptokinase. These are usually used when there is a blood clot involved with a STEMI, and it's given when PCI is not available within 2 hours of the first medical contact, and then it's followed by heparin. Beta-adrenergic blockers should be administered as soon as possible to help improve survival rates by decreasing the heart rate and reducing the work of the heart, along with decreasing oxygen demand. ACE inhibitors may also be given because they can minimize abnormal shaping or ventricular remodeling. And then if there's any dysrhythmias, we want to provide some antiarrhythmics. Percutaneous coronary intervention, or PCI, is the first choice of treatment for an MI with the goal of reopening that occluded artery within 90 minutes of arrival to the ER, or 2 hours from the first medical contact. Angioplasty will dilate areas of plaque obstruction, and stents might be placed to help hold those occluded vessels open. Plaque can also be removed in the coronary arthrectomy or the laser angioplasty. Complications of this procedure would be a coronary artery dissection, dysrhythmias, coronary spasms, hematoma, or bleeding, restenosis, and death. The coronary artery bypass graft, aka CABG, saphenous veins or the internal mammary artery are frequently used to help create a bypass to an occlusion. In the first procedure, the incision would be made at the sternal area, the heart is stopped, and the patient is placed on a cardiopulmonary bypass machine. There's a second procedure that would require a small anterior thoracotomy incision, and this procedure is completed on a beating heart. With this procedure, the hospital stay and postoperative ventilatory support is decreased. A third option, which is off-pump coronary artery bypass, also uses the incision at the sternum, but it is completed on a beating heart. A newer procedure makes 3 small incisions on the chest and uses an endoscope to complete the procedure on a beating heart. There's less recovery time, but the procedure actually takes much longer to complete. And a different method of revascularization for the patient who is not a candidate for a CABG is the transmyocardial laser revascularization, in which 10 to 50 holes are drilled into the myocardium using a laser to help provide collateral circulation to ischemic tissue. So MI patients are going to require close monitoring, oxygen, analgesics, IV lines, drug therapy. They need to be kept calm. Cardiac rehabilitation to minimize the risk of adverse cardiac events should begin as soon as the patient is stable. This is done through education, medication, lifestyle modifications, etc. And each of these are going to be individualized for each patient. And here's a mnemonic to help you remember the 4 first-line treatments that we provide to a patient we believe to be having an acute MI. And this shows the 3 areas of damage following a myocardial infarction.